Hello, good morning. I'm delighted to be here. Thank you for inviting me. Some of you may know me or remember me. I'm originally from Malta. I did my postgraduate training in Glasgow when I worked with Professor Folds, who did a lot of work in ocular oncology. And then the proton beam machine opened up near Liverpool, so I moved to Liverpool. There wasn't an oncology service there, so I started a new oncology service, which is still going strong. And then about 5 years ago, I was invited to redevelop the ocular oncology service in San Francisco, which is what I did, and now it's doing well under the leadership of my successor there. And I came back to Britain the end of August, and now I'm working 2 days a week in Oxford, setting up a diagnostic and follow-up service in order to reduce the workload on the oncology centres. And I'm also doing a locum job 3 days a week at Moorfields for the next few months until Mrs. Cohen comes back to work there. So this morning I'm going to speak about ocular melanomas to discuss the natural history and the treatment and how that might affect the history. And this afternoon I'd like to speak about the care pathway and the patient's experience and how that might be improved. So when we speak about ocular melanomas, we should distinguish between the conjunctival melanomas and the intraocular melanomas, uveal melanomas. And they're completely different from each other. The conjunctival melanomas are like the skin melanomas, and the uveal melanomas behave totally differently, they're genetically different, and so on. So the uveal melanomas, about 9 out of 10 of those are under the retina, at the back of the eye. And then there's a few that arise in the ciliary body, near the lens, and a very small number arise in the iris, which is the colored part that you can see. Most of you present around the age of 60, but there is, of course, a wide spread. It's very rare before adulthood, and men and women are affected in equal numbers. So some melanomas arise out of nowhere, de novo. And here's a patient in 2012. The back of her eye was totally normal. And then up to the right, over here, you can see a dark area, and I think that's the smallest melanoma I've ever seen. The patient had a very astute optometrist who took photos every year, and so it was possible for the optometrist to look back at previous pictures and to see that the spot was new and it wasn't there before. So this patient shows how melanomas can arise out of nowhere. And when they're very, very small, they're indistinguishable from benign moles. Rarely, melanomas arise from a malformation, a birthmark, where there's more melanocytes. Melanocytes are the pigment cells. And if there's more than usual, then there's a higher chance than usual of developing melanoma. And eyes are a different color, the skin's a different color, the back of the eye is a different color, and that's where melanomas can develop. And then intraocular melanomas can also arise from this benign tumor known as a melanocytoma. It's with about a 1 in 300 chance of transformation to melanoma. So melanomas can arise from moles as well as out of nowhere. When they're very small, this is what they look like. They're slightly raised, dome-shaped, and the uvea, between the uvea and the transparent retina, there's a membrane known as the pigment epithelium. It's like tiles on the wall. And that becomes damaged by the melanoma underneath. And you tend to get these orange clumps, orange pigment, lipofuscin, which shines up, and this pigment shines brightly on a special test known as autofluorescence. And because the pigment epithelium is not working, it's like a pump. It pumps away water from underneath the retina. And when it doesn't work properly, you get fluid collecting under the retina, you get a retinal detachment. And that shows up nicely on a test known as OCT, optical coherence tomography. And then, as these tumors grow, they form a sort of dome-shaped tumor. It can either be lightly colored or dark. And these are measured very accurately with ultrasonography. And down to your left, you can see an ultrasound scan showing the tumor. And then sooner or later, the tumor breaks through the pigment epithelium and sort of prolapses into the retina. And it sort of gets strangulated by a rigid membrane, and the veins become congested and leak fluid, and the tumor swells and develops a mushroom shape or a collar stud shape, as you can see in this ultrasound scan here. A small proportion of uveal melanomas are diffuse. They spread so aggressively that they don't have time to form an actual lump. And quite often they extend outside the eye by the time they're diagnosed. So these have to be distinguished from benign moles, nevi. There you can see one in an adult. And moles don't usually grow except in teenage years. And here you can see how a small mole has grown in a 14-year-old boy, but then they stop growing and they just sit there for the rest of the patient's life. They're quite common moles. About 1 in 8 of us has a mole. I've probably got one, for all you know. But some moles are different from others. They're a little bit bigger, a little bit more lumpy, and there's different names for this. You can either call it an atypical nevus, or a suspicious nevus, or a possible melanoma, different names. So it can be difficult to distinguish a large nevus, a large mole, from a small melanoma. And that's causing lots and lots of problems because, especially for medico-legal reasons, optometrists are becoming much better at detecting these things because they've got better cameras, optos cameras, wide-angle cameras, so they're much better at seeing things at the back of the eye. And for legal reasons, they're worried about looking after these spots. So they're sending everybody to hospital. And there's so many patients going to hospital that they're flooding the system. It's creating a big crisis and getting in the way of patients who really do need treatment. And that's why I've been given this job at Oxford, to try and find a way to solve that problem. So what I've done to try and make it easy for optometrists and general ophthalmologists to distinguish benign moles from malignant melanomas, I've developed this device as mnemonic, which is moles. So if there's a mushroom shape, it's a melanoma. If there's orange pigment, it's a melanoma. If it's big, it's a melanoma. If there's visible growth after teenage years, or if there's subretinal fluid, it's a melanoma. So there's a little table here, and you tick the boxes, and there's a scoring system. And if the score is less than 2, then the patient doesn't need to see a specialist. If it's 2, then they should be watched regularly. And if it's more than 2, then they should see an ocular oncologist quite soon. And over the next 2-3 years, I'm going to see whether this concept works. Because, as you can imagine, the sooner we detect these tumors, the better the chances of keeping vision, keeping the eye, so perhaps survival. But small tumors and big moles, small melanomas, big moles, can be difficult to distinguish. So here's a patient I saw in San Francisco a few months ago. followed for several years. Slight growth. What should we do? Is the mole, is the melanoma? Well, we did a biopsy, and it showed, despite the fact it was very, very small, it showed it wasn't just a melanoma, but it was a life-threatening melanoma. And so the patient had treatment instead of further observation. So with regards to treatment, in most places, the first choice of treatment is plaque radiotherapy. How many of you have had a plaque? There you see. And in Europe, most of us use ruthenium plaques, which give radiation, a beta radiation that only travels a short distance. So there's less chance of damaging the nerve or the fovea or the lens, unless the tumor is very, very close to these structures. And down below, you can see melanomas before and after treatment. The white area is a sort of scar that you get around the tumor. And one of the things I've done is to develop a sort of dummy plaque, which is non-radioactive, because these radioactive plaques are dangerous for the hospital, for the theater staff, especially when you're putting in several of these in a day and several times in a week and several thousands of times in a career. So first we use a plastic dummy as a sort of dress rehearsal. And once we know it's in the right place, we loosen the sutures and put in the real thing. And it's much safer doing it that way. And the results with plaque are very good if the plaque is inserted by somebody who's experienced and has got the skill to put the plaque in the right place. In Britain, we've also got proton beam radiotherapy. This is a giant gun. How many of you have had proton beam treatment? Not so many. And it's a big gun, very expensive, near Liverpool. And it fires protons at the tumor. And these protons are like little bullets, and they damage the DNA, and the tumor dies. The advantage of that is that the treatments are more foolproof. If we don't do our measurements too precisely, the computer corrects our mistakes, and the aim is sorted out so that you can really get the tumor. So the chances of killing the tumor are very, very good. The problem with that treatment is it has to pass through the front of the eye, so it can cause cataract, can damage the eyelids, the tear ducts, and so on. So I've been very lucky to be able to choose between the two treatments. So if I can see that, look at the tumor and say I can put a plaque there quite reliably, that's what I do. If not, the patient gets proton beam and everybody's happy. Then the other treatment is transpapillary thermotherapy, where we shine some infrared laser at the tumor for about a minute, just to heat the tumor up by a few degrees. And that's enough to knock all the metabolic processes out of sync, and so the tumor dies. And that's how that patient was treated with a very tiny tumor. You can see how I can really focus the laser very, very precisely. This, down below on the left, you can see a picture taken a few minutes after the laser where the retina is showing a bit of a burn, and that's the eventual scar at the end. And the lump has completely gone. Well, it actually was too small to form a lump. That's the smallest melanoma you can imagine, and that's a scar afterwards. So in the right patients, you get the right results. There's quite another form of treatment. Instead of the hot laser, there's the cold laser. I like to call it the cold laser. And with that treatment, you inject a dye into the arm, wait for it to reach the eye, and then you shine infrared laser, cold laser, that activates the drug, so it releases toxic oxygen molecules and so on, that kill the tumor. And the treatment has progressed a lot over the years. In the 1980s, I treated 2 patients with verteporphyrin derivative, and they got sunburnt afterwards because it wasn't just their tumor that became light sensitive, but the whole skin, and they got sunburnt in Glasgow in midwinter. And so we stopped using it. But it's been used for lots of other cancers, not just we weren't just sort of experimenting like that. And then recently it's been used for macular degeneration, and now it doesn't cause so much light sensitivity. But recently Aura have been making progress with a different drug that's injected into the jelly of the eye, and it finds its way into the tumor, and then you shine light at the tumor and it's supposed to shrink. We have to wait and see how that works. It's very recent. For big tumors, they're too big for radiotherapy, too big for laser. There's a few surgeons who can remove the tumor surgically from under the retina. What you do, you make a big trapdoor in the eye, and then you cut the tumor, and then close the trapdoor, and then give a bit of radiation in case there's any seeds left behind. It's a very, very difficult operation. I only learned how to do it when I was 31, because Professor Folds taught me. He was one of the pioneers of that surgery, and I've done a few hundred of these. But it requires a skilled team, especially anesthetists, to lower the blood pressure, and so very, very few surgeons are doing this operation. Here's somebody I treated with a very big tumor in his only seeing eye, and then afterwards he got a vision of 6/6, which is kept very, very well. They don't all do as well as that, but this patient shows what is possible. Another way of removing the tumor is to suck it away with a vitreous cutter, a vitrector. Vitrector is like a little tube with a guillotine at the end. And you pass it through the eye, into the back of the eye. There's also a little torch that you put in the eye and a little tap to keep the eye, to put fluid into the eye. And you cut the tumor into little bits and then suck away all the bits and then give some laser, maybe radiation treatment. And that can save vision in some patients who otherwise would become blind in the eye. And there's a patient I treated who came to me from Australia because I think it was because he was a golf fanatic. You know, people who play golf will do anything to be able to continue to play golf. And he came all the way from Australia so that he could continue to play golf. And he got a brilliant result with this endoresection. It's a very controversial operation because people imagine that if you cut a tumor up into bits and you don't suck away every last bit, it's going to come back with a vengeance and kill the patient and destroy the eye and so on. But experience with more than 100 patients shows that that doesn't happen. So people imagine that these behave like dandelions, these melanomas behave like dandelions, you blow it and it spreads. I'd like to say that these tumors behave more like bee colonies. When the queen bee decides to swarm, the tumor swarms somewhere else, whether or not you go anywhere near it. And the data support that. And the endoresection is also useful after radiotherapy, because what happens with radiotherapy is that the radiation damages the arteries and veins inside the tumor, so that they leak fluid and the tumor becomes deprived of oxygen, and it stimulates hormones that stimulate new veins on the front of the eye, on the iris, or you get lots of fluid collecting under the retina, you get severe retinal detachment. And I call this a toxic tumor syndrome. And one way to treat this is to remove the toxic tumor, either by exoresection or by endoresection. So there's lots of different ways to treat uveal melanoma. Some of us are privileged to have a choice. When we see a patient, we can pick the best treatment for that particular patient. But in many centers, there's no choice. All they have is plaque and nothing else, either plaque or enucleation, or proton beam and enucleation. And that's it. So with regards to the small ciliary body tumors in the front of the eye, you can see them with a special ultrasound scan, and by a little trapdoor, you can remove the tumor quite nicely. And then on the iris, if you remove the iris, when I was started working in ocular oncology in 1984, the standard treatment was an iridectomy, but then instead of having a small round pupil, you have a big pupil, lots of light coming into the eye. And I had a patient who refused my advice, rejected my advice to do the standard treatment because she worked in Antarctica. And she was afraid that she wouldn't be able to go back to Antarctica because there's a lot of light from all the snow in Antarctica. So I said, look, why don't we just treat this radiotherapy? I've never heard of this being done, but as long as you understand that, we can give it a try. So we treated her with proton beam, and she's done very well. She did very well, and then I treated the next patient who also did very well, and now it's a standard treatment around the world for iris melanomas. So here's another patient. So why do we treat patients with uveal melanoma? Why do we treat the eye? Well, the hope is that we prevent spread of tumor to other parts of the body. If we can also save the eye, so much better. And if we can save vision, great. As long as the vision's not distracting. But in 1996, this German group produced this very, very important paper that changed my professional life. And it showed that these melanomas, uveal melanomas, develop a mutation in chromosome 3. And if there's that mutation, it looks as if all patients die, or almost all, if they live long enough to get their metastasis. If they don't have that mutation, then they all seem to live with their normal life expectancy. And so that gave rise to the impression that by the time we first see the patient, their future is decided. So nothing we do to these patients makes any difference to their survival. So we're just treating symptomatically. And very often, sadly, that's the case. You know, the patient comes too late and the tumor is already spread. But are we ever there in time to prevent spread? Should we be trying to treat these early, or is it always too late? Well, during the time when we thought that there was treatment didn't make much difference, there was this patient who we watched because the tumor was small and not doing anything and indolent. And the patient was diabetic, so treatment would have made the eye blind. And then suddenly the tumor grew, and we removed the eye. And at the base of the tumor, the old part of the tumor, there was one genetic type, the good genetic type. And in the new part of the tumor that had recently grown, there was a very dangerous, life-threatening genetic type. And this patient taught me that tumors can change from being good to being bad. These melanomas, you can get a good melanoma that's not life-threatening and a bad melanoma that is. And it can change at a late stage. And in some patients, this change happens very early. In some patients, it happens very late. You don't know when it's going to change. So that's why we must treat everyone as quickly as possible and as early as possible. So the past few years, there's been an explosion in knowledge in genetics. And a lot of these, and Boris Bastian at UCSF, where I worked until recently, discovered the GNA mutations that cause nevi in the eye and melanomas. And also BAP mutations that are associated with metastasis. There's other mutations too, but the BAP1 is a very important one. And so the whole approach is changing, the prognostication and treatment is changing thanks to these discoveries. So with prognostication is really important because it totally affects our treatment. It influences whether we refer the patient to an oncologist or not. It influences the counseling that we give. It influences the screening that we recommend, all these things. And I'm sure you all want to know Well, what I've learned from my patients is that everybody, all of you want to know the prognosis, and that you find it much less stressful than not having a clue. At least most of you. There are exceptions always. But our studies with our patients have taught us that most patients, a large majority, want to know the prognosis, good or bad, so that they're empowered to do what they can if there's a bad prognosis. So, apart from genetics, the standard treatment, the standard way to estimate the survival probability is the size of the tumor. The bigger the tumor, the bigger the risk of tumor coming back in the liver. And the standard way of system is the TNM staging system. And I was fortunate enough to be involved in that study and to give data on 3,500 patients, 3,600 patients to develop this. But you can get big tumors that are not dangerous and small tumors that are dangerous, so this only gives an approximate indication. And then there's the microscopic appearances of the tumor. If the cells are long and narrow, that's good. If they're round and big, then that's bad. If you can see lots of cells dividing under the microscope, that's obviously bad. There's various features like that. So in Liverpool, what we did, we collected all the data over many, many years. Fortunately, we were lucky to be able to do genetic studies from 1998. The German paper came out in 96. In 1998, I think it was 88, 98 or 99, we were able to start doing genetic tests on our patients. And we're very lucky that NHS England paid for our genetic tests. What happened was that I went to my hospital and I told the managers there that we're treating the eye, but we're not doing anything for survival. And if our patients ever found out that we were just focusing on the eye, they would never forgive us. And amazingly, the hospital in Liverpool paid for a full-time postdoctoral research fellow with a PhD to translate the German research findings into a clinical tool. And that's why we're able to start. And then I spoke to NSCAG in those days in NHS England, and I said, look, we must do genetic testing on these patients because our studies confirmed the German results. And first they said no, because each test cost £500. And then when I told them we would have to scan everybody forever, say every 6 months, and when they realized how much that would cost, then they agreed to pay for these genetic tests on condition that we evaluated the results and proved whether it worked or not. And now it's becoming standard practice around the world. So in Britain, we've been ahead of the game. So this tool is on the internet for ocular oncologists when they see a patient to enter the age, the gender, the tumor size, the genetic type, the microscopic appearances. And like that, we're able to get much more accurate predictions than was ever possible previously. So here's a patient with, on the left, there's a patient with a big melanoma. You'd expect it to have a bad prognosis, but actually the genetic test showed no dangerous mutations. And on the right, there's a patient with a tiny little tumor. You'd expect a really good prognosis, but genetically it was a terrible melanoma, and sadly the patient passed. So this influences our screening, and we'll hear more about that in a few minutes. And thanks to screening, we're able to do more. Thanks to selecting patients, we're not wasting precious resources on patients who don't need screening. Not just the hospital's precious resources, but also the patient's precious resources, because it costs patients money and time off work and traveling and so on. And recently, thanks to this fantastic discovery, well, it's not a discovery, it's a long period of research from Immunocore, and it's great to see the team from Immunocore here. For the first time, we're seeing a treatment that's producing dramatic results, and we're going to hear more about that later. A few words about conjunctival melanomas. That's how I like to draw the conjunctiva. You've got the diffuse melanomas, just in the very thin layer of the epithelium without any invasion, and they're treated with chemotherapy drops. And then you've got the nodular melanomas, which do very well by surgical removal, followed by a bit of radiotherapy, as long as they're not too big. But as I mentioned before, the conjunctival melanomas are totally different from the intraocular melanomas, genetically and everything, so that when you read about melanomas and you read about dramatic response rates, like this patient I saw in San Francisco, his eyes were full of tumors that had come from the skin, and with systemic treatment, everything disappeared, and he's still alive and well. His hair has turned white from the drugs, because the drugs have affected the melanocytes, the pigment cells, not just in the tumor, but in the skin as well, and in the hair follicles. And we've been seeing these dramatic results with skin melanomas, but not with uveal melanomas. But thankfully, there's lots and lots of excitement about recent Immunocore ImmTAC treatment of uveal melanomas. We'll be hearing more about that later. So this is an overview of the natural history, the way these uveal melanomas grow, and what they look like when we look at them under the microscope, and when we look at the back of the eye, how we treat them, and the impact on survival, or the lack of impact on survival, and prognostication. And this is the ophthalmic perspective on uveal melanomas. And later on, I'll speak about the patient's experience from our point of view. Thank you very much.